Okay, so thank you, esteemed panelists. Our index patient is a 55-year male with HCV CLD. He had pulmonary tuberculosis, was treated 10 years ago. And after 5 years, he presented with constitutional symptoms, and on evaluation, his alpha-fetoprotein was more than 50,000. It was child A. On triple phase MR, that was an HCC, large HCC, 10 centimeter HCC involving anterior sector and portal vein tumor thrombosis of right anterior portal vein, right posterior portal vein, and entire main portal vein. As I said, is CLD child A. Okay, this is the arterial phase MRI. I'm not running through the videos. This is the arterial phase involving the portal vein, enhancing tumor thrombus in the portal vein. This is the portal venous phase. So, our challenges are in the background cirrhosis, a large tumor with main portal vein tumor thrombosis, and alpha-fetoprotein above 50,000. So, questions to the panelists. Dr. Sainath, what comes to your mind with such a large tumor, alpha-fetoprotein more than 50,000, and tumor PVTT in main portal vein? What comes to your mind? Is it like curative or palliative?
From a practical point of view, most of these patients end up with palliative care. But again, with the newer drugs, immunotherapy drugs, there is some hope. The reason why I'm saying this is we still don't know what is a perfect marker, who will respond. So you have to treat all them and keep an eye who is the exceptional responder. So, but without that, if you have to look at the hard data, most of these patients, 3/4 of these patients, or more than that, in fact, would end up being palliative.
Okay. Naeem, as a surgeon, when you come across such patient to begin with such a large tumor, what would be your thought process initially?
At the outset, it looks like a very bad tumor. It's a diffuse infiltrative pattern of tumor, the VP4 tumor thrombus, and AFP more than 1 lakh. So first thing comes to my mind is it's probably a metastatic disease. So I would like to rule out a metastatic disease, and probably do a if you're planning anything, then you should also probably do a biopsy to see if it's a poorly differentiated tumor or anything else.
Dr. Naveen, triphasic CT was done, MR was done, PET CT was also done. They said no distant metastasis, alpha-fetoprotein. So do you want to consider any other investigations apart from this at this stage?
I think looking at the MRI and the CT definitely looks like a very infiltrated tumor. So as Naeem says, it's a pretty bad disease. It's a very high chance of metastatic disease. So yes, PET would definitely help us to understand what is going on in terms of extent of the disease. With high AFP, infiltrated disease, VP4, poor prognosis for this patient. In previous days, we would have actually said immunotherapy, especially patient has got good performance status, we would have said immunotherapy and wait and watch, but I think now we're talking about downstaging, so we'll probably discuss about it. I think any other investigations probably won't add any more value. I would not do PIVCA here because it's not going to add any more value. So I think we got enough investigations to tell what the stage of the disease is.
Yeah, great. Dr. Shantan, so role of biopsy we have discussed, all the investigations have been discussed.
Yes.
So at this stage, when that anti-treatment or maintenance is there, what do you want to consider first?
Yes, now with a well-established diagnosis of hepatocellular carcinoma with VP4 tumor thrombosis, so if you're going for BCLC, if you're saying the inacil modification, it's coming at to C1. So still there's a chance of downstaging, so I would definitely consider downstaging followed by the possibility of liver transplantation, saying into the context that he is well preserved and he is in child A. Now, out of the possible options we're given, we are ruling out TACE, we are ruling out currently which are as a second line medications. So coming into possibility of TARE or immunotherapy, there are two issues. Now we deal with the VP4 tumor thrombus and we deal with the liver lesion. Being it the infiltrative lesion, large lesion, possibility of TARE followed by decompensations is higher, and the liver reserve is currently unknown. So I would definitely go for starting with the immunotherapy, see how he responds, and add on SBRT for the VP4 tumor thrombosis, and I won't touch the SBRT for the lesion itself currently.
Yeah, thank you. So our medical oncologist, Dr. Sainath, is there. They were treating this patient. Probably they have taken the right decision. Of course, they offered TARE also, both immunotherapy and TARE, but patient family was not that willing for TARE since it is an invasive procedure, and they consulted multiple doctors. So considering this AFP of more than 15, they started immunotherapy as a palliative intent. So,
sorry, sir. Do you do any ICG-15 retention? Indocyanine, because now with the retention, we don't know the quantitative assessment, qualitative assessment. So
okay,
normal
functional studies.
Functional status.
Functional
Yes,
studies.
yes, yes.
So as for this patient, for this index patient, it was not performed. Okay. Maybe it can be considered in future. We do functional studies in nuclear medicine.
So only my concern with the large lesion and with infiltrative, with the introduction of TARE, if the patient decompensates, then the problem arises. So that is a reason which I was asking.
True. We are doing functional studies for resection patients and as well as for living donors, but not exactly before considering for TARE. So coming to the treatment, our medical oncologist started. They started with lenvatinib. They gave for 10 days, and by the time the family has decided and they're not willing for TARE, and both options were given immunotherapy. Immunotherapy was started by Dr. Sainath and Dr. Santosh. And they gave 3 cycles. So question to Dr. Sainath, at what stage or after how many cycles you want to reassess for this index patient as well as in general for any other patient?
So generally, I mean, just to add to one of your previous questions, in any patient whom we are trying to do atezolizumab and bevacizumab, we will always look for the varices, because the risk of variceal bleed for a grade 3 varices after bev is very high. So after setting that, assessment will be dependent. Most of the times what we have seen is, I mean, not from the downstaging liver transplant point of view, but if the fall of AFP's fall is good in the first 4 to 6 weeks, it is ideally we do it after 3 cycles. But sometimes the fall is slow, and we do know some segment of these patients take a longer time to respond to immunotherapy. In those patients, preferentially it is 4. But most of the trials have done generally after 2 to 3 cycles. 3 would be ideal.
Okay. So that's what our team did. Reassessed after 3 cycles. There was a partial response that was very motivating. And the team continued with the rest of the cycles. So at index presentation, alpha-fetoprotein was more than 50,000, and after 3 cycles, it was again more or less same. But there was some reduction in the size and some reduction in FDG, FDT. So continued 3 more cycles of same combination, and after 6 cycles, when they did PET CT, the tumor has really shrunk, and FDG, FDT was also reduced, and there was of course faint FDG, FDT in the main portal vein, suggests for some viable tumor, probable viable tumor in the main portal vein. You can compare with PET CT done at 3 cycles and after 6 cycles. So at this time, after 6 cycles, alpha-fetoprotein has nicely come down to 5. And at this point, so my question to Dr. Naeem, so alpha-fetoprotein is normal. Almost the intrahepatic tumor has, the metabolic response is complete, but there is a faint FDG, FDT in the main portal vein, suggestive of probable viable tumor in the main portal vein. So what do you want to consider now?
Since the tumor has shown a remarkable response and there is some avidity in the portal vein, I would like to treat the portal vein tumor thrombus with SBRT.
So Dr. Naveen, what about your comments considering faint avidity in the main portal vein and alpha-fetoprotein is normal? So do you suggest any loco-regional therapies at this point to target main portal vein?
Yeah. So I think just coming back to the point about the atezolizumab bevacizumab, although the study says 3 cycles, generally we give for 6 cycles and then reassess is what my practice has been. And after 6 cycles as well, we reassess, and then based on the response, we'll continue with the cycles. Now, I think coming to this case here, in particular, main portal vein thrombosis, middle portal vein thrombosis is there. So, so what I would suggest here is definitely SBRT, as been discussed, because mind you, this patient has got well preserved. We're looking at curative intent now, rather than being just a palliative treatment. So, I think definitely SBRT, followed by reassessment is what I would also suggest.
So,
My only other question is whether we continue with any other TKIs along with it. I probably wouldn't. Just give SBRT and then wait and watch.
That's what, very nice, Dr. Naveen. And our team, at this point, to be honest, actually, since it was very encouraging, we primed the family for probable liver transplant, considering the huge response with immunotherapy after 6 cycles. So at this point, we informed the family that probably we can contemplate for liver transplant. Dr. Srinivas is also here, our hepatologist. We did this when I was in my previous organization. Then we added SBRT to sterilize the main portal vein. So after 6 cycles and after SBRT we did 4 weeks ahead of planned liver transplant. This is the PET CT just before liver transplant. There was complete metabolic response, both intrahepatic tumor and as well as in the main portal vein. And alpha-fetoprotein was consistently less than 2 or 3. So patient, this is the serial PET CTs. The last row is just before the transplant. There was no FDG avidity at all, both in intrahepatic and also in the main portal vein. So, Dr. Naeem, would you like to consider for transplant now? Since the tumor has been completely sterilized, there is a complete metabolic response both in the liver as well as in the main portal vein, and alpha-fetoprotein is also normal.
Yes, because the patient has shown a very good response after immunotherapy and SBRT. Starting with, didn't look like the patient would go for a transplant, but the kind of response he has shown, I think we could offer him transplant after the cooling period.
That was the time, it was like 2.5 years back. So we had to discuss with few centers in Mumbai and Bangalore, Mumbai Global and Bangalore. Global had performed 2-3 transplants. We had to discuss with them about the cooling period. Daughter donated and patient underwent uneventful liver transplant. Coming to the interval between the last cycle of immunotherapy and actual transplant was 11 weeks. Dr. Shantan, what about cooling period? Are you okay with this 11 weeks?
Yes, I think previously Dr. Prashant's already informed that we need for 2 half-life of the drug to be eliminated. So that would make up to almost 6 weeks. So there was a meta-analysis in 2022 which showed the average time of 4 weeks, but that was more of nivolumab related, whose half-life is less than the atibeva. So when we see atibeva half-life is coming up to almost 3 to 4 weeks, so ideal time would be more than 6 weeks. So that's fine.
Yeah, this was the preoperative CT image just before the transplant. There was complete portal cavernoma, and we put a jump graft to take inflow from the superior mesenteric vein. Post-operatively, he did very well, and he received standard triple regimen immunosuppression. There was no episodes of rejection. So this is the pathology, histopathology specimen. There was radiologically and as well also pathologically, there was a complete tumor response. There was no viable tumor in the specimen. So follow-up, every 3 months, patient underwent either PET CT or CT. Alpha-fetoproteins were consistently less than 3 for the last 2 years. And since it was the jump graft, it's a distorted image. I just wanted to show the patency of the jump graft from the superior mesenteric vein. Now we followed for 2 years. It's exactly 2 years now. And alpha-fetoprotein is less than 2 and no recurrence. He's leading normal life. Of course, we had to stent him for biliary stricture. So my question to Dr. Naveen, this was a decision taken by our oncologists, to be honest. They were in the front line in managing this patient till we contemplate transplant. I really congratulate them. This was like 2 years back. After that, many such transplants have happened. So suppose if you come across such kind of patient, do you want to give the same regimen of ICAs, Beva and Atezo given? Do do you also consider the same regimen now, or you want to change?
I think the atezo and bevacizumab has become the first-line therapy for most of our HCC patients. So definitely, yes, we have seen similar kind of results with our case series as well, where we're able to downstage them. Of course, to liver transplant to certain people were able to downstage to local regional therapies, we're able to prolong their life. So I think times have changed where we're downstaging, stage migration is definitely possible for these patients. Even for metastatic disease also, for people, we had patients where we had bone mets as well, we're able to downstage to where we were actually able to do a transplant. So definitely immunotherapy, particularly atezolizumab, definitely has been a wonder drug.
Thank you. My question to Dr. Sainath, as Shantan also said, there are some unfavorable factors to consider for tear, like in this case is an infiltrative tumor, and also if biopsy was done, if it is a poorly differentiated tumor, mostly they may not be responding for tear, and also main portal vein involvement. If it is a necrotic tumor, they won't respond for tear. It's a general consensus like. So my question to Dr. Swainath, what are the predictors of responsibility to immunotherapy? Before starting immunotherapy, are there any subtle factors so that we can happily start immunotherapy instead of tear or TACE?
So now the recommended immunotherapy regimens, apart from atezo-bev, which we had 2 years ago, the only regimen, now we are spoiled for choices. We have Durva-Trem and also Nivo-EP. Nivo-EP is awaiting approval in this segment. The first thing is we always look at what is the etiology of the background liver disease. So most of the cases where it is because of the viral cause, they are likely to have a better response with immunotherapy as compared to the NASH. And there is subtle data coming up, when you use a dual checkpoint inhibitor, durvalumab with tremelimumab, they do better. The NASH patients do better with that dual checkpoint inhibitors as compared to atezo and bev, which is an angiogenic inhibitor. So these are the subtle considerations we have to take. But when, in the previous talk and what we are seeing, the upcoming data, the systemic analysis, the vitality analysis, what we have seen is there is definitely certain segment of patients where downstaging and transplant can be done, especially with portal vein thrombosis without extrahepatic disease. When we see if it's because of wider etiology, no extrahepatic disease and this thing, the choice would preferably be atezo-bev, because most of the transplant post-IO has been with this regimen. We don't know how dual checkpoint inhibitors do, because the risk of graft rejections when you are using a CTLA4 inhibitor is theoretically high. We need to see how it does. Even after the pooling period, we have to see, because a lot of the CTLA inhibitors might actually take longer time. And most of the experience, is the case series and the retrospective analysis, is with atezo-bev. So if it is extrahepatic, no extrahepatic disease, viral etiology, there is a good scope of downstaging, it is atezo-bev. If it is NASH or hepatic extrahepatic disease, where these are the ones who don't do so well, probably even a dual checkpoint inhibitor is also an option.
Yeah, thank you. I hope we got the take-home message. I'm skipping this slide. This was the previous team. When I was in my previous organization, we did this transplant. Let me congratulate all our previous team members. Thank you from Apollo. Thank you. Any questions from audience? Dr. Prashant is a master in HCC from India. No HCC session gets complete without any comment of Dr. Prashant, and also I need some comment of Dr. Srinivas Reddy also.
Raghu, I think they are short on time, so
yeah,
I don't want to make any elaborate comments. Only one comment. Once a metastatic disease, it's a no for liver transplant for me. Even if it is downstaged, even if you would wait for 1 year, I would not transplant the patient who has had metastatic disease already. And for me, a patient who's got an infiltrative tumor, apart from the fact that, if there was less of function and the risk of decompensation from tear, infiltrative tumors per se are bad for tear. The responsiveness of tear in large infiltrative tumors is bad. So I think I won't make elaborate comments more.
No, thank you. Thank you, Dr.
This patient was probably lucky. He responded very well. Of course, we can't draw any concern. Dr. Reddy. Yeah.
No, I think this is an excellent case. I wanted Dr. Raghunathan to present it because it just shows that, times have changed. These are cases, we can't say no to any patient now. There are options that we should try. If the patient comes through, that's good. That's good for the patient, that's good for us. I mean, if it doesn't come through, then we tried our best. I think that's what message I wanted to give. Thank you. Thank you.
Thank you, panelists, for all your comments, suggestions. Thank you.